Padmavati. She is the chief and head of the Neuro Ophthalmology department in Aravind Eye Hospital, Tirunelveli since 2005. She has won many best paper awards in TNOA and All India conferences, and she has been a reviewer of instruction courses and many free papers in All India and Tamil Nadu conferences. And she is going to talk about supranuclear pathway and disorders. Over to you, madam.
A very good afternoon. At the outset, I would like to thank Dr. Kalaimati for giving me this opportunity and honor to deliver a lecture in KSOS. Back 2 years, we were on online. I think this is the first time I am giving an offline lecture. The topic assigned to me was supranuclear pathway and palsies. Actually, this cannot be covered in 15 minutes. But still, I'll try to do justice for the speech. Many times, I think everyone would have wondered, why do we require eye movements? In order to keep our vision steady, you need to fixate at a target. So, in order to focus, your point of precision should be on the fovea. And you have to have a main fixation to view the object clearly. Apart from that, there are many activities which are going, you tend to read. You just ask the letter or you scroll the letters, you tend to see an eye movement. Apart from that, have you ever wondered, when you walk, still you are able to read the book clearly? What makes you read the book very clearly? So there are different mechanisms in our neural mechanisms which help us to maintain our vision steady. One is your vestibulo-ocular reflex, which even during any rotation, you are able to fixate on a target. The next is you are fixating on the target to view it properly. Apart from that is your optokinetic nystagmus. So all these, what do these things do? They hold the images on the retina. View this video. You can see a boy seeing a thumb. He is fixating on the thumb. He is moving to one side and he is moving to the other side. So what are the systems or what are the movements associated with it? One is your pursuit. You are following a target. As the target is moving, you are moving the object. That is the pursuit. The next is your saccadic system. When you look at one target, suppose someone comes, you tend to do a corrective movement. So that is a saccadic system. Apart from that, when you are focusing, your vergence system comes into play. So these movements direct the fovea to object of interest. Okay. So whenever you have a limitation of movement, the commonest thinking is it is the nuclear level palsy. So what happens is whenever you have a nuclear association, the muscle is palsied. But there are certain conditions where the nucleus is under the control of supranuclear centers. So I am going to be speaking about these supranuclear as well as the internuclear. In order to look horizontally, what makes you to look one side? Suppose I want to look to the right. What is the center? It's your parapontine, the horizontal gaze center. It is called the parapontine reticular formation, which is in the pons. So this is the one center which coordinates your eyes to look to the right. To right, it is the right PPRF. For the left, it is the left PPRF. Suppose you want to look vertically. What is the center? This center is situated in the midbrain, which you call it as a rostral interstitial nucleus of the medial longitudinal fasciculus. It is in the midbrain. So this center coordinates your eyes to move vertically as well as torsionally. Coming on to the horizontal gaze pathway, you have if you want to look to the left, your left PPRF should be stimulated. But the command has to come from the right frontal field. I'm sorry. So the command comes from the right frontal field to the left PPRF, from which it goes to the sixth nerve nucleus, which innervates the left six lateral rectus. Through the MLF, it is the innervation also goes to the medial rectus. So this is the horizontal gaze saccadic pathway. So any affection in along the pathway has a limitation of movement. For the vertical gaze, as I said, there is a different pathway for the upward as well as the downward saccades. From the RMLF, you have through the fibers going to the oculomotor nucleus, that is the elevators of the same side for upward gaze. So it is a bilateral representation, one to the same side elevators and also to the contralateral superior rectus as well as the inferior oblique. For the down gaze, you have from the RMLF, you have the excitatory burst neurons which innervate on the same side. The inferior rectus nucleus on the same side, oculomotor nucleus, and the superior oblique of the nucleus on the same side. So the muscle will be the opposite, the nerve will be the other side. Before you, in order to look to one side, you have certain neurons within the PPRF as well as the RMLF. You call them as the excitatory burst neurons, which stimulate the motor neurons to fire so that the agonist muscle goes into the proper position against the what you call as against the forces of the muscles as well as the orbital pull. So from the excitatory, you have the impulse which is going on to the agonist muscle. At the same time, if you are looking to the right, your right lateral rectus, what happens to the other muscles, your right medial rectus as well as the left lateral rectus? Someone has to say, you don't function, this is functioning. So you have the inhibitory burst neurons, which is going to the antagonist muscle, which doesn't allow to function. Always the excitatory burst neurons is not going to be fired. If you are going to have continuous firing of the excitatory burst neurons, you are going to have more amount of bizarre movements. So this is something under the control of the omnipause neurons. So the omnipause neurons will not function when there is a saccade. After the saccade is generated, it is going to get reduced. In order to maintain to that position, you need to have something of a frequency of a pulse, and in order to maintain in that position, you need to have a step or something which is maintained. Suppose I want to look to the right. To the right, if I am looking, there are certain centers which I will try to maintain my gaze on the right. So what is the structures which is involved in making you look to the right or maintaining? To look to the right, your PPRF is functioning. To maintain to look on the right, you have something called as the neural integrators. This is different for the vertical as well as the horizontal. For the vertical, it is the interstitial nucleus of Kajal. For the horizontal, it is the medial vestibular nuclei. So moving on to the saccades, which is one of the fastest eye movements. It is a conjugate eye movements which brings the object of interest onto the fovea. Suppose you see a picture, you make multiple saccades to view the image. Whenever you examine any neuro-ophthalmic case or whenever the patient presents with diplopia, it is mandatory you see the ductions as well as the versions as well as the vergence. So as you see the saccades, you have to have between 30 to 40 degrees apart two targets. You have to measure horizontally as well as vertically. You have to see the latency, velocity as well as the accuracy. How accurate it stops short of the target. The next is your pursuit. The pursuit is a system. This is a slow eye movement where you track a object. Suppose you are moving, still you are able to track an object. There is one entity which is the vestibulo-ocular reflex. When you try to rotate, even then you are able to focus on the object. So this is a smooth pursuit. You have to see how smooth it is initiated and how it is following the target. The pathway for pursuit is a bit complex, where you perceive the objects in motion, which goes to the visual cortex. From there, it through the magnocellular pathway in the lateral geniculate body, it goes to the striate cortex, then goes to the parietal cortex. From there, it is into the projects to the frontal eye field and medial superior temporal field. There is actually here, this is a bit complex. There is always a double decussation, one to the cerebellum from the vestibular nucleus to the horizontal gaze center. So this is how it is followed. The next is your vestibulo-ocular reflex. This is the reflex act which connects the balance organs and eye movement structures. This keeps our vision steady when we move by moving, whenever we move instantaneously our eyes in the direction opposite. Suppose you thrust your head to one side, your eye movements goes to the other side. So what are the structures involved in that? You have the semicircular canals as well as the otolith organs. The three semicircular canals which are responsible for the angular vestibulo-ocular reflex, which includes when you turn your heads to the side, up and down. The next is your otolith organs, which is the saccule as well as the utricle, which is involved in your linear vestibulo-ocular reflex and ocular tilt reaction when there is a movement with turning with respect to gravity. These are the things which are going to, suppose you tilt your head and you're moving, or when you are driving in a car, you are able to visualize the things properly. So the vestibular nuclei, it is always connected to the oculomotor nuclei. One is the third and fourth to move the eyes vertically as well as torsionally, and sixth and third to move the eyes horizontally. This keeps our vision stable and you are able to maintain a visual horizon whenever with whatever position you make with your head. The next is your optokinetic system. This is tested predominantly by the foveal fixation and pursuit. This actually complements the vestibulo-ocular reflex. This is usually with a handheld drum, black and white stripes. You should test it horizontally as well as vertically. Next is your vergence, which helps in depth tracking of an object. This is governed by the parietal occipital frontal lobe, which increases with age. The midbrain lesions usually cause a convergent defect, whereas pontine lesions cause a divergence defect. So we'll move on to the abnormalities of the saccade. Whenever you say the abnormalities of the saccade, it could be any saccadic oscillations, intrusions, or initiation, or any abnormal latency. If you see this video, the movements are a bit slow. You are not seeing a pursuit. This is actually a saccade. It is a slow saccade. So this is an abnormal velocity which is often seen in a spinocerebellar ataxia type 2. Watch this girl who presented with abnormal eye movements. When you give a target, she doesn't move her head, she thrusts her head to see the object. Yeah, that's right. So this is a case of congenital oculomotor apraxia, which you call it as a Cogan's oculomotor apraxia. Here you have an increased latency, or you could call that as a saccadic initiation failure. The newer terminology is saccadic initiation failure. These head thrusts are there to trigger the vestibular guided saccades. And moreover, this is associated with several diseases. The location of the lesion is not known. Apart from that, you can have square wave jerks, opsoclonus, etc. The next is your gaze palsies. See the head turn of this elderly lady with hypertension. She was a 60 years old female with hypertensive etiology. She had a face turn to the left. If you can see, she is able to move up, but to the right she is not able to move. If you can see, there is a facial palsy also associated with it. So this is a case of right horizontal gaze palsy. This is at the level of the nucleus. So you have a lacunar infarct in the parapontine formation. This is a PPRF. If you can see how is it differentiated from a nuclear lesion. The right gaze is not there. To the left, the eyes are moving. But if you see through the vestibular ocular reflex, you are able to perceive to the other side. So the differentiation is you tend to have loss of ipsilateral horizontal eye movements as well as voluntary saccades and involuntary saccades. Smooth pursuit and vestibular ocular reflex are spared here, whereas here you have an associated facial palsy. You can see the abductive nystagmus. This is a case of internuclear ophthalmoplegia. I think I'll take another 5 minutes. Is that okay? Or if I can stop short, I'll stop short. Okay, fine. So whenever you have a lesion in the PPRF, you have a saccadic palsy. When you have the lesion in the sixth nerve, it is a gaze palsy. In the MLF, it is internuclear ophthalmoplegia. Bilateral MLF, it is a wall-eyed bilateral internuclear ophthalmoplegia. With the PPRF MLF, it is 1 hand and half syndrome. This is a video of a patient who has a vertical gaze palsy. Is not able to look up. You can see the saccades are very poor. Down also he is not able to see. He had an infarct in the midbrain. Okay, I think. So bilateral lesions are usually common, usually associated with infarct of the posterior subthalamic artery. So when you have the lesion in the posterior commissure, you have upward eye movements affected, down gaze deviation and downbeat nystagmus. So when you have pursuit abnormalities, whenever you have in this area, it abolishes the smooth pursuit, whereas in the frontal eye field, it is an impaired ipsilateral pursuit, whereas in the medial superior temporal, it is a decreased velocity and amplitude. When it involves the cerebellum, it is impaired ipsilateral pursuit. The gaze deviations where you send horizontal or it could be vertical. When it is to the same side, it is in the frontal lobe. If for seizures, it is to the opposite side. Pontine lesion, it is to the opposite side. Vertical deviation you tend to see in post-encephalitic Parkinsonism. You call that as an oculogyric crisis. So convergence insufficiency you see usually in Parkinsonism as well as progressive supranuclear palsy. You can see the patient is not able to follow the target. The pursuit is almost very slow. So you can call that as a saccadic pursuit. Here the convergence is also very poor. So this you call that as a progressive supranuclear palsy where your vertical gaze paresis is worse for downward than superior. And the pursutic saccadic it is called. You tend to have absent convergence as well as OKN which may be diminished. The last is when you have an affection of the cerebellar thing, the saccades are hypermetric, or you can call it as a dysmetria, where it is overshooting the target. So it could be a saccadic dysmetria, pursuit, or it could be unstable fixation. You tend to have an vestibulo-ocular suppression in these cases with gaze-evoked nystagmus. To conclude, you have to identify the characteristics of the ocular movement, correlate with associated neurological findings and neuroimaging. Thank you for your patient hearing.
Thank you very much, madam. That was a wonderful talk. And next is Dr. Neena. She is a senior consultant and head of the department, Pediatric Ophthalmology and Neuro-Ophthalmology, Giridhara Institute, Kochi. She is going to talk about optic neuritis newer developments. Yeah. Over to you, Neena.
Thank you, Dr. Kalai, for this opportunity. Thank you, KSOS. So, without much introduction. I'll just directly go into the topic. We know that the optic neuritis, there has been a lot of changes, basically because there has been a revision of the diagnostic criteria. There has been discovery of newer antibodies, basically the anti-aquaporin 4 and anti-myelin oligodendrocyte associated glycoprotein antibody. There has been an availability of newer investigations, and we have new development of immunosuppressants and monoclonal antibodies. So all this has improved our understanding of optic neuritis and associated diseases. So this is a basic classification of optic neuritis. You can classify it as a typical or atypical. Typical would be associated with demyelination when it is associated with MS or isolated. Atypical would be if it is associated with inflammatory or infectious conditions or other cases. So these are the common infectious causes of optic neuritis. The atypical ones are the ones we need to really look out for. It can be associated, any of these, NMO, MOG. I'll come to each of this later. So what is a typical optic neuritis? We know that that's an inflammatory demyelinating condition, usually affecting a young patient, usually a female with painful loss of vision, most commonly presenting as a retrobulbar neuritis. And the literature says Caucasians and people living in the higher latitudes and temperate climates are more affected, and demyelination associated with MS is the most commonly reported cause in the Western world. So these are some terminologies you should be aware of. One is isolated optic neuritis. Second one is relapsing isolated optic neuritis, chronic relapsing inflammatory optic neuropathy, MS-associated optic neuritis, neuromyelitis optica associated optic neuritis, and myelin oligodendrocyte antibody-associated optic neuritis, because each of them are different in their own way. So what's prevalent in the Asian scenario is quite different from what is reported in the Western literature. We have more of NMO and MOG-associated optic neuritis here, with more of papillitis rather than retrobulbar neuritis. So we will come to that later. So these are the red flags which would tell you which is not a typical optic neuritis and which is an atypical optic neuritis. Now, the importance of MS, I'm not going into detail. Everybody knows that 20% of the MS patients can have optic neuritis as their first episode of demyelination, and 50% of the MS patients will develop optic neuritis during the course of disease. But the funny thing is that the revised 2017 McDonald's criteria does not have any does not have the MRI lesions in the optic nerve as one of the diagnostic criteria. So optic neuritis is not included as one of the diagnostic criteria for MS. So these are the common neuroimaging findings. I'll just skip it due to lack of time. Let's go to neuromyelitis optica spectrum disease. Now, this is something which we are understanding better and better day by day. So what we understand is that this is a most severe form of demyelinating optic neuritis associated with an antibody known as anti-aquaporin P4 antibody. If it is positive, we say it is seropositive NMO spectrum disease. If it's negative, it is seronegative NMO spectrum disease. So this is associated with frequent relapses, poor vision, very profound vision loss, and the recovery is also not very good, often associated with transverse myelitis, bilateral involvement. So the left-hand side shows you the MRI pictures with swelling and enhancement of the right optic nerve, and it could be a long optic nerve involvement. Even the chiasm could be involved. So what basically happens is aquaporin P4 is a water channel which is present at the foot process of the astrocytes, which facilitates water movement across the cell membrane. So when there is an antibody to that, there is a complement activation, damage to the astrocytes, there is demyelination. That is how the whole pathway gets activated. So coming to the other entity, which is the MOGAD or the anti-MOG associated disease, in which there is antibodies which are against the MOG, that is the myelin oligodendrocyte glycoprotein, which is a glycoprotein located on the oligodendrocyte and myelin sheath, which is again important for the functioning of the whole process, and there is demyelination in that antibody-antigen reaction. So what is different in anti-MOG disease? Here, the age group is little different. So the MS patients are typically 20 to 40 years. MOG usually affects the age of 31 to 37 years. More or less similar male-female, whereas the MS affects females more. Here again, there is more of disc edema or papillitis-like presentation rather than a retrobulbar neuritis presentation. And the important thing is that they have excellent visual prognosis with steroids. However, the recurrence are quite high. Okay, and in children, this is one of the most common causes of optic neuritis, and it causes up to 50% of acute demyelinating events in children. And MRI shows this characteristic optic nerve enhancement. Sometimes even the perineural enhancement or the nerve sheath enhancement is thought to be very typical of MOG disease. So this is a beautiful table which I've taken from Saxena et al.'s article in IJO, which compares the various different types of optic neuritis, MS optic neuritis, anti-aquaporin optic neuritis, and MOG optic neuritis. So a newer entity called glial fibrillary acidic protein IgG astrocytopathy has been described, and the antibodies are apparently detected in some patients, though it has, I don't know whether it is, we are doing it here in India. Now, another important entity is CRION, or chronic relapsing inflammatory optic neuropathy. It presents like a typical optic neuritis, responds beautifully to steroids. The minute you stop the steroids, it recurs. And you have to put the patient again on steroids. You stop again, it recurs. So eventually you will have to maintain the patient on long-term steroid therapy and eventually on immunosuppressants. I had one patient who had bilateral hip fractures because of the chronic steroid therapy, and she had to be put on azathioprine eventually. So it has a long course, but it responds well. COVID-19 saw the onset of variable types of optic neuritis associated with the disease as well as with vaccinations. We are all familiar with that. Pediatric optic neuritis. We know that pediatric optic neuritis is a little different from the typical optic neuritis we see in the adult population. We have more of papillitis-like presentation, more of bilateral presentations, and the vision loss is more pronounced in pediatric cases, with more than 50% of the children presenting with very poor vision at presentation. And MOG is supposed to be the most common cause. At least in India, we find that MOG is the most common cause of optic neuritis in children. And some of them may even progress to acute demyelinating events. So that is, they also have higher relapse rates, but they respond very well. So how do we approach? This is a typical working pattern of an optic neuritis. So we give IV methylprednisolone according to the weight for all the patients. Then we definitely send them for a neurology consultations and serology to rule out the MOG and the NMO spectrum and MS if at all. MRI, of course, is done at the initial stage itself, not for diagnosis, but for prognostication. And if the patient does not respond to treatment, then you have to talk to the neurologist and think about whether it's falling into any of the NMO MOG spectrum if the antibodies are positive, and think about considering IVIG or plasmapheresis. And depending on the response, you may have to maintain the patient on steroids for long-term duration or switch over to immunosuppressants. Now, this was an update of optic neuritis where they recommend early intervention if it is atypical, not the one which is typically described in the Western literature. So this is again an approach taken from Saxena et al.'s article from IJO. So nowadays we are doing routinely serology in all cases of optic neuritis because we are getting more and more seropositivity, especially with MOG. So are serological tests is needed? Yes, because we need to know the long-term prognosis of the condition and which test is important. Serum testing is better, cell-based assays are better. And CSF studies is definitely indicated in patients with MS suspicion and also to rule out infections and in some other conditions in which you are suspecting rare cases. So ONTT definitely gave us some gold standards about how to treat optic neuritis patients, and we still follow it. But in Indian patients, we do give IVMP for 5 days, and we do give for a longer duration than the routinely prescribed 11 days. Now, treatment is very different from MS and for NMO and for MOG. So if it is MS, you offer immune prophylaxis after the initial IV steroids. So you have disease-modifying agents like beta-interferons and immunomodulators like glatiramer acetate and dimethylfumarate and fingolimod and monoclonal antibodies. But if it is NMO and NMO spectrum disease, you don't give immune prophylaxis. You put them on immunosuppressants. So that is the difference. So azathioprine, methotrexate, MMF, rituximab, these are the ones which we use. And again, a lot of studies are going on, newer therapies which look at optic nerve regeneration and remyelination. So take-home points would be optic neuritis is a clinical diagnosis. We can all diagnose optic neuritis. MRI is not required for the diagnosis, but it is the most important ancillary test because it can confirm the diagnosis and also prognosticate and rule out the masqueraders. And you should order an MRI brain and orbits with contrast, with flare sequence, and CSF studies. And serology should be done ideally in all cases, suspicious cases, MRI spine, and definitely think about atypical cases when you have atypical findings. Thank you.
Thank you, Dr. Neena, for finishing on time. And next topic is approach to optic disc edema by Dr. Kalemati. Dr. Kalemati is senior consultant, cataract and comprehensive ophthalmology department, Giridhar Eye Institute, Kochi. Over to you, Dr. Kalemati.
Good afternoon, everybody. My topic is approach to a patient with optic disc edema. Optic disc edema could be either unilateral or bilateral and with or without vision loss. So unilateral with vision loss could be because of demyelination if the age group is below 50 or because of non-arthritic AION if the age group is after 50. And if there is no vision loss, it could be either pseudopapilledema or a raised ICT which is asymmetrical. And if it is bilateral without vision loss, it could be due to increased ICT. And if with vision loss, it could be either NMO or MOG type of optic neuritis. A pseudo-disc swelling often is seen in a routine examination in an asymptomatic patient with marked hypermetropia or myopia. But in case of true disc edema, the patient will complain of headache, nausea, vomiting, pain during eye movements, sudden or gradual vision loss, transient obscuration of vision, pulsatile tinnitus, diplopia, etc. So we have to ask history regarding trauma, surgery, systemic diseases, drug intake, miscarriage, and dehydration. And in examination, we have to check vision, color vision, pupillary examination, ptosis, proptosis, extraocular movements, slit lamp examination, fundus examination, blood pressure, and record the temperature, and also palpate for the thickened temporal arteries. These are the points to note for in true disc edema. The blurred disc margins, flame-shaped hemorrhages, obscuration of vessels, dilated veins, the SVP will be absent, and disc hyperemia. Now coming to the cases, a 5-year-old child came for a routine examination and the disc looked like this, bilateral blurring of disc margins. But with +6 dioptosphere, the child vision improved to 6/6. So it is a case of hypermetropic disc, pseudo-disc edema. An 18-year-old boy came with headache, vision 6/6N6. The bilateral fundus picture showed bilateral disc edema. OCT showed some globular bodies here, and autofluorescent there was hyper-autofluorescent substances in both eyes, and in ultrasonography showed hyperreflective bodies in both eyes. So it's a case of disc drusen. In case 3, it's a 56-year-old male, right eye blurring of vision, mainly in the inferior region, 1 week duration, vision 6/6N6, blood pressure, everything was normal, right eye superior disc margin, obscuration of disc margin, and OCT is like this, inferior altitudinal defect, so it's a case of AION. 50-year-old female, sudden diminution of vision, right eye, 1 day duration with severe pain, RAPD right eye, color vision defective, and optic fundus picture is like this, and OCT, visual fields. MRI was suggestive of optic neuritis. IVMP was given and she improved. 52-year-old female, blurring of vision, both eyes, 3 weeks duration, and pupils sluggish, non-dilating, severe anterior uveitis. IOP was very low, 4 in both eyes. This is the slit lamp picture of right eye, left eye. This is the fundus picture. Both eyes disc, disc edema with choroidal detachment and severe anterior uveitis. This is the OCT picture, and it's a case of VKH. Steroids were given and improved. 70-year-old female, right eye, diminution of vision for 2 days, RAPD right eye disc edema, and treated as AION. And later on, both eyes cataract were done. After 10 years, she presented with left eye disc edema and diminution of vision. And the vision, this left eye disc is like this. At that time, the right eye disc became pale, and this is a case fields or shows altitudinal field effect. It's a case of sequentially non-arthritic AION pseudo-Foster Kennedy syndrome. The risk factors should, we have to keep the risk factors under control. 42-year-old female, sudden blurring of vision with headache left side, 2 days duration, no fever, color vision normal, no RAPD left eye. Here there is left eye disc elevation with macular edema. So we suspected neuroretinitis, and blood was sent for testing. This is and here we can see the macular star with disc edema. This is a disc edema. MRI was normal, and toxo IgG came out to be positive, treated with clindamycin and visolone, and she improved. So 60-year-old female, left eye diminution of vision, 2 weeks duration, sudden onset, RAPD left eye, color vision decreased, only disc edema. And this is the OCT. And in the MRI, there was minimal thickening of the optic nerve sheath alone. So it's a case of optic perineuritis. So tapering dose, visolone was given and tapered, and she improved. 43-year-old man presented with severe headache. BP was 220/120, both eye florid disc edema. It's a case of malignant hypertension. 67-year-old gentleman, headache, vomiting, left-sided weakness, 1 week duration, both eye disc edema. MRI showed a mass lesion, which was meningioma. And 28-year-old obese lady with PCOS and both eye disc edema. MRI showed lateral sinus thrombosis, and MRV was also taken. So bilateral disc edema, we have to think of in any intracranial lesions or dural venous sinus thrombosis or idiopathic intracranial hypertension. 35-year-old lady, throbbing headache, nausea, tinnitus, vision was okay. The florid disc edema, constricted fields, MRI showed IIH. She underwent VP shunt, and the fields improved after that. So investigations that should be done after, in a case of disc edema or OCT, autofluorescence, angiography, fluorescent angiography, ultrasonography, fields, CT scan if MRI is contraindicated, in MRI with contrast with MR venography, LP, and neurology or neurosurgical consultation if necessary. To conclude, history, examination, investigations, and imaging aid in the diagnosis. Persistent disc edema of any cause causes permanent damage to the optic nerve. Bilateral disc edema is a medical emergency, and prompt diagnosis and timely intervention is crucial in salvaging the life and vision of the patient. Thank you.
Thank you, Dr. Kalaimati, for that nice talk and beautiful cases. Next, we have Dr. Sujitra, Professor, Amrita Institute of Medical Sciences. She is the head of the Department of Oculoplasty and Bioethics. She will be talking about traumatic and ischemic optic neuropathy. Over to you, Dr. Sujitra.
Good afternoon. And thank Dr. Kalaimati for including me in this instructive course. I'll be presenting few cases. So first case, his 28-year-old male. He presented with loss of vision in right eye following a road traffic accident. His visual acuity in right eye was doubtful perception of light. There was proptosis, restriction of all ocular movements. left eye was normal, and CT scan showed fracture orbital floor, medial wall, and there was hematoma in the orbit and in the sinuses. So hematoma, evacuation of the hematoma was done through lateral candolysis and anterior orbitotomy, and fracture floor was reduced. He improved, his proptosis improved, but vision did not improve. And this case is a 57-year-old male. He presented with a decrease in vision in right eye following RTA, and he reported 4 days after RTA. His visual acuity in right eye was 6/60, with improving to 6/18 with pinhole. Left eye vision was normal. Right eye RIPD, color vision was defective, and fundus was normal, both eyes. And CT scan showed fracture in the sphenoid sinus on the right wing with mild indentation of the optic nerve. So IV methylprednisolone was given for 5 days, then switched to oral steroids. Vision improved, and his field of vision is also improved. And 27-year-old lady presented with loss of vision in right eye following RTA. His right eye vision was PL plus, PR accurate. There was RAPD, and fundus was normal. And CT scan showed fracture orbit and hemosinus. Again, IVMP was given, and orbital decompression was done. And she showed improvement in visual acuity and visual fields. So we analyzed about 34 patients with traumatic optic neuropathy. They presented to us, and the age of presentation is about 35. Most of them are young, and males are commonly affected, and road traffic accident is the common cause, and indirect traumatic optic neuropathy is more common, and it is commonly associated with orbital wall fractures. And among the orbital wall, lateral wall fracture is commonly associated with traumatic optic neuropathy. And 5 were managed conservatively without any treatment. 24 patients received steroids, and surgical decompression was done for 5. And eyes with poor presenting visual acuity, had poor visual improvement, poor visual outcome. And lateral wall fracture was the most common fracture associated with indirect traumatic optic neuropathy and with poor visual prognosis. Coming to traumatic optic neuropathy, the mechanism may be either direct or indirect. Indirect traumatic optic neuropathy is the most common form of traumatic optic neuropathy. Here, the trauma causes shearing on the nutrient pile vessels, causing traumatic optic neuropathy, or the force of impact on the forehead can be propagated and focused on the orbital apex and causing optic nerve injury. Direct optic neuropathy can be either due to impingement by the bony fragment or due to orbital compartment syndrome due to hemorrhage. Orbital hemorrhage is an ophthalmic emergency that is an indication of immediate surgical management. And direct optic neuropathy can be due to penetrating injury or transection of nerve fibers or compression from hemorrhage, edema, or impingement by foreign body. Optic nerve avulsion, which is rare, and it causes severe, profound visual loss, and it presents with vitreous hemorrhage. And we have to rule out skull base injury. Here, if we suspect hematoma, we have to do CT and MRI imaging so that we'll be able to pick up the optic nerve sheath hematoma. So symptoms would be visual loss. Most of the time, we won't be able to assess visual acuity since the patient will be in ICU with loss of consciousness or orientation. We may have to depend on pupillary reflex. Signs again, pupillary reflex is very important to suspect traumatic optic neuropathy. Ophthalmoscopy, most of the time it be normal. If there is optic nerve avulsion, there will be hemorrhage. For the optic atrophy to develop, it takes about 4 to 6 weeks. So again, evaluation, that is first his pupillary reflex, then imaging. CT scan is more important if we suspect bone fractures, and if there is no metallic foreign body, then we can do magnet MRI. So there is no effective treatment for this traumatic optic neuropathy. There are many studies which support steroid, megadose steroid, and some studies says that there is no definite improvement with steroids. So still it is controversial whether to give steroids or no steroids. But one thing is very specific, that steroid is contraindicated in patients with traumatic brain injury. So in orbital hematoma, we have to intervene immediately and reduce the orbital pressure, which improves the visual recovery. Coming to ischemic optic neuropathy, it is broadly categorized into anterior ischemic optic neuropathy, posterior ischemic optic neuropathy, and radiation-induced ischemic optic neuropathy. So here again, 52-year-old male presented with blurring of vision. He noticed that defective vision while waking up in the morning. His known case of hypertension and obstructive sleep apnea, not on regular medication. His visual acuity was 6.669. Color vision was partially defective. There was RAPD, and field showed inferior altitudinal field defect. So it is a typical presentation of non-arthritic AON. Here again, management is managing the risk factors. If the patient presents before, if there is a young patient, if the patient is young, less than 50 years, we have to investigate for hyperhomocystinemia, protein CRS deficiency, or antithrombin 3 deficiency. Imaging should be done if there is any atypical features or systemic malignancy or progressive vision loss. And MRA or CTA should be done if we suspect any problem with carotid circulation. So again, there is no definite treatment for that. We have to manage the risk factors. 68-year-old male presented, they were referred from cardiology for ocular examination. He gave history of sudden onset painless loss of vision in right eye 1 month back, and he had painful loss of vision in left eye 5 days back. Visual acuity was counting finger close to face in right eye, and left eye 6/60, and right eye disc was pale, and left eye there is pallid disc edema, and ESR and CRP was raised, and imaging showed occlusion of internal carotid artery and external carotid artery. So there is combination of NAION, or in left eye there is arthritic AON. He was started on steroids and anticoagulants. So this patient is a leukemia patient undergoing chemotherapy, and he gave a history of blurring of vision for 6 months duration, and fundus examination showed pale disc, and there was altitudinal field defect, so probably posterior ischemic optic neuropathy. So it can be either arthritic, non-arthritic, or hemodynamic compromise. Severe anemia or hypovolemia can cause posterior ischemic optic neuropathy. Here in acute stage, the fundus is normal, and in chronic stage, there will be optic atrophy. And radiation-induced ischemic optic neuropathy happens in patients who undergo radiotherapy for pituitary adenoma. So it is a very slowly progressive optic nerve disorder where there is ischemic demyelination and fibrinous necrosis due to radiation injury. Here again, there is no definite treatment. Prevent the improved radiation protocol can minimize this radiation induced optic neuropathy. Thank you.
Thank you, Dr. Sujitra. That was a wonderful talk. Next, we move on to the next talk about cranial nerve palsies by Dr. Rehna. She is an assistant professor in Department of Ophthalmology, Amrita Institute of Medical Sciences. Over to you, Dr. Rehna.
Good afternoon. First of all, let me thank Dr. Kalaimati for giving me this opportunity to present in this instruction course. The topic is cranial nerve palsies. In this presentation, I'll be dealing mainly with third, fourth, and sixth cranial nerve, which innervate the extraocular muscles of the eye. The course of the cranial nerves can be divided into nuclear, fascicular, basilar, intracavernous, and intraorbital. First of all, let's go through anatomy a little bit. The oculomotor nerve nucleus is situated at the midbrain at the level of the superior colliculus. There are two nuclei, the main motor nuclei and the Edinger-Westphal nuclei, and it's related to other important structures such as red nucleus. And it is composed of an unpaired levator palpebral superioris nucleus, which is innervating bilateral levator. So any lesion causes bilateral ptosis. Then there is a paired superior rectus nucleus, which is innervating the contralateral superior rectus. Then the paired inferior rectus, inferior oblique, and medial rectus subnuclei, which is innervating the ipsilateral side, and an impaired Edinger-Westphal, which is innervating both the pupils. The main lesions are vascular infarctions, primary and secondary metastasis. Oculomotor nerve is entirely motor and it supplies all the extraocular muscles and the levator except the lateral rectus and superior oblique. So fascicular lesions, it depends upon the site of involvement and another structure which is affected. So I'll rush through this. There are different syndromes depending upon the other, like if the red nucleus is involved, it's called Benedict syndrome with associated contralateral extrapyramidal signs. In Weber, the cerebral peduncle would be involved, causing contralateral hemiparesis. North-Nangle, superior cerebellar peduncle, and Claude is a combination of Benedict and North-Nangle syndrome. So basilar course is when the nerve exits the brainstem and is coming out before piercing the cavernous sinus. Here, it passes between the posterior cerebral artery and the superior cerebellar and parallel to the posterior communicating artery. At this point, the nerve is actually traveling alone, and so the isolated lesions can occur in this region. Having said that, the trochlear nerve and abducens nerve also go through the same path, except that they are inferiorly lowered down. So what is pupil sparing third cranial nerve palsy? At the basilar portion and at the cavernous portion, the pupilomotor fibers are actually superficial in the nerve, and it's supplied by a pile plexus. But inside, or the main trunk is supplied by the vasonervosum, so if there is an ischemia, the main trunk is affected, sparing the pupillary motor fibers, and thus causes a pupil sparing third cranial nerve palsy. And after the basilar portion, it goes into the cavernous sinus where the nerve fibers are arranged like that, oculomotor, then comes the trochlea, the first and the second divisions of the trigeminal, and the abducens nerve at the center along with the internal carotid artery. So here, any lesion causes multiple cranial nerve palsy at the cavernous sinus. And different lesions which occur here are pituitary apoplexy, diabetes, aneurysms, or meningioma. So after exiting the cavernous sinus, it goes through the orbital apex into the orbit. It goes through the superior orbital fissure, which is actually a cleft which is formed between the greater and the lesser wings of the sphenoid. And the nerves are clustered here with in the annulus of Singh, we have the superior and the inferior divisions of the oculomotor and abducens nerve. Here we have LFT, lacrimal, frontal, and trochlear. And once in the orbital, once inside the orbit, it supplies the corresponding muscles. So the presentation, the eye would be turned out and down. There will be complete ptosis if it is complete involvement. and there will be limitation of elevation, adduction, and depression, and the pupils will be dilated, and there will be absence of both direct and consensual. Going to the trochlear nerve nucleus, it's located in the midbrain, but it's at the inferior colliculus, and it is the only nerve that exits through the dorsal portion of the midbrain, and it's the longest and the slender nerve. The causes, that's mainly idiopathic, which is congenital. Other causes are trauma, microvascular conditions, aneurysms, and tumors. Clinically, if it is congenital, the patient may be asymptomatic, except that there would be a head tilt. And the diplopia, if it is acute, it will be vertical. There will be limitation of depression. So this nerve is tested in depression in adduction. So if there is a third nerve involvement as well, then we have to do the same and look for whether the eye is indoting. Okay, and bilateral involvement, there will be right hypertrophy on the left gaze and left hypertrophy on the right gaze. Let's look at the Park 3-step test. Here in the primary position, the eye is hyper. When the patient is moving to the opposite side, hypertrophy is increasing. And on head tilt, it increases to the ipsilateral side. That's why in superior oblique palsy, the patient tends to adopt a head tilt to the opposite side to relieve the diplopia. The sixth cranial nerve nucleus, it's located at the pons, and it's also related to important structures like facial nucleus, facial colliculus, medial longitudinal fasciculus, and the cerebral corticospinal tract. So depending upon the site of involvement, there will be associated features like facial nerve palsy or the fifth nerve involvement. And once it comes out of the brainstem, at the CP angle, it's closely related to 7th, 8th, 5th cranial nerve, and it goes up and reaches a petrous temporal bone where it's related to trigeminal, and then pierces the dura into the cavernous sinus into the orbit. The causes of 6th cranial nerve palsy could be ischemic. Any case of 6th nerve palsy, you have to do a complete neurological examination. In case of tumors, if it is CP angle tumors, look for the 7th nerve, 5th corneal sensation, and also the hearing. Another cause is trauma. Then we all know elevated ICT. So dilate the pupil and look for papilledema. And infections like medullary infections and meningitis causes like medullary infections called Grady-Negro syndrome, facial pain, and 6th nerve involvement. So that is the presentation. The patient will present with diplopia, and it's uncrossed diplopia. The primary position eyes will be ESO, and there is limitation of abduction, and the face will be turned to the ipsilateral side. So whenever you see multiple cranial nerve palsy, it's not benign microvascular. Should think about something else. As I said, in superior oblique fissure, the multiple cranial nerves are there. So simultaneous involvement of 3, 4, 6, and the 5th cranial nerve locate the lesion to the cavernous sinus. So if it is bilateral involvement of the cranial nerves, it suggests a diffuse processes like infiltrative lesions, malignancies, leukemias, or a midline lesion that extends bilaterally like nasopharyngeal carcinoma or a meningeal process. In superior orbital fissure, we already said it will be multiple cranial nerves, and if the lesion is at the orbital apex, optic nerve will also be involved, and the patient presents with decreased vision with multiple cranial nerve palsies. So this is one of our patients who presented with decreased vision, and he had proptosis on the left side, complete ptosis, and limitation of movements in all cases, and absence of consensual on the other side. So differential diagnosis in such cases, of course, orbital apex, cavernous sinus, especially if the patient is systemically unwell. SOF syndrome, in fungal infection should be suspected like mucor. If the patient is severely debilitated or has uncontrolled diabetes. Tolosa-Hunt syndrome is an inflammatory process involving the superior orbital fissure and the cavernous sinus. So how do we manage? These patients should undergo MRI brain CT angiography, especially if it's a pupil involving third nerve, a painful ophthalmoplegia, worsening cranial nerve palsy, partial or not improving. If it is a pupil sparing, or if it is 4th nerve or 6th nerve, you want to observe if it is not improving beyond 6 weeks and younger age of the patient. An MRI orbit should be included if you are suspecting orbital apex or superior orbital fissure. And if you are planning to observe and thinking about vascular causes, rule out diabetes, hypertension, a lipid profile, ECG, BP should be done. Treat the underlying cause. If ischemic, usually resolves in less than 3 months. In between, you can occlude the eye, or prisms can be used to avoid troublesome diplopia. Surgery for the ptosis or strabismus should be considered only after 6 months and the ptosis or the deviation is stable. Thank you.
Thank you, Dr. Regana. As I think we don't have time for discussion, we'll wind up. I invite Dr. Kalamedi to give small memento to our madam, Padmavati madam.
started.